my object today is to teach a little bit about a scope of practice with the medical assistants. I was blessed and had the opportunity to work at BCC and teach the first class of medical assistants. But I also worked at South Coast and taught the medical assistants there before I moved to Sturgis. It's been nice being an RN and also having the law degree because some of this hinges on the law. So I look at it in a different perspective, so hopefully you'll be able to enjoy it. So, definition of a certified medical assistant. A medical assistant is a graduate from a post-secondary medical assistant education program accredited by the Committee on Allied Health Education and accredited of American Medical Association or its successors. The Accrediting Bureau of the Health Education School or its successors, or such other certified program as the Commissioner of Public Health shall approve. The medical assistant is employed by or in a medical practice of a licensed primary care physician or person. And I'll go into that because it's not just a physician that they speak to or that they report to. There are other professional entities that they do. And this person performs basic administrative, clerical, and clinical duties upon the specific authorization. Unfortunately, in Massachusetts, we don't have a clear-cut scope of practice for the practitioners that we face. Rhode Island does, but we don't. And I think at the end I have some information about if you're looking for what the Rhode Island scope of practice is. And that's important because sometimes the courts will, if something came up, the courts will look at not only what's in the state. If they find that we don't have something very specific for the medical assistants, they may look to other neighboring states and say, oh, but Rhode Island has a scope of practice that says that they can do A, B, C, and D. The courts will look at that to determine if the medical assistant should or should not be doing that. So let's talk about primary care providers. A healthcare provider qualified to provide general medical care for common health problems who supervises, coordinates, prescribes, and otherwise provides or purposes healthcare services. They initiate referrals. The medical assistants can't do that, but they can tell the medical assistant, I need this person to have a referral. And they maintain continuity of care within the healthcare professional scope of practice. And depending on who they are and what they are will determine what their scope of practice. Everybody in Massachusetts, nurses have a scope of practice, the physicians have a scope of practice, the NPs have a scope of practice. So everybody, healthcare analysts, I think except the medical assistants, have a very defined, specific scope of practice. So a primary care provider, or PCP, is a person we first see for checkups and health problems. PCPs can manage your overall health. If you have a health care plan, you need to find out if they will cover this PCP. There are certain plans out there that will only let you see people who are in network. So you need to find out if this person is in your network or not. The term generalist often refers to medical doctors and doctors of osteopathic medicine, DOs, who specialize in internal medicine, family practice, and pediatrics. OBGYNs are doctors who specialize in obstetrics and gynecology, including women's health care, wellness, and prenatal care. And many women will use their OBGYN, especially younger women, will use the OBGYN as their primary care. As you get older and then you start getting the hypertension and all these other diabetes, and all these other wonderful things, that's when you find that you probably need more than just an OBGYN doctor. You're going to need a PCP. Nurse practitioners are nurses with graduate training. They can serve as primary care providers in family medicine, pediatrics, adult care, or geriatrics. Others are trained to address women's health cares, and there are many women's centers that have nurse practitioners. A nurse practitioner can work independent of a physician. They can start their own practice. So that's something else that is a little bit different than, say, a physician's assistant or of course medical assistant. Physician assistants can provide a wide range of services in collaboration with the doctor of medicine or the doctor of DO. So a physician assistant is different from a nurse practitioner where they have to work with a physician. A lot of our orthopods have PAs that work with them in their practices, and they take them to the OR and they assist in the OR and do that type of thing. All right, scope of practice. In some states, medical assistants have a specific stated scope of practice, such as Rhode Island, which I have already stated. In Massachusetts, there's no specific law to address this issue. Mass General Law states that medical assistants work under the direct supervision of a licensed primary care provider. Now, that doesn't mean that they have to be next to them in the room while they're doing something. If a medical assistant needs to give a shot, an IM or an SC, they can do it, and they don't have to have the physician in the room. If they need to take out sutures, if they need to take out staples or look at a dressing, they can do that without the physician in the room. But the physician or the practitioner has to be in the facility. They have to be available. If there's a problem or an issue, they need to be available that they can come in and find out what the problem is and evaluate and assess what that patient needs. And that's a big difference. Okay, so let's talk about meaningful use. There's a lot of terminology when people talk about meaningful use and how it's related to healthcare. Meaningful use is using certified electronic health record technology to improve quality, safety, efficiency, and reduce health disparities. It engages patients and families. It improves care coordination and population and public health. It maintains privacy and security of patient healthcare information. That's all that HIPAA stuff that's out there. That's what this does. And ultimately, it's hoped that the meaningful use compliance will result in, and this is for our patients and our clients, a better clinical outcome because there's more coordination with this. Improved population outcomes. Patients have better outcomes once they leave your facility, whether it be a healthcare facility or a hospital, or a doctor's office, they leave in a better position. Increased transparency and efficiency. That way there's no questions about the care that's given or how it's given or who's giving it or what tests are being done, and also empowers the individual. The patients now have a say in what their care is and how it's delivered. Meaningful use sets up specific objectives, and eligible professionals and hospitals must achieve to qualify for centers for Medicare and Medicaid services. Everybody knows it as CMS incentive programs. And what that basically speaks to is financial. It's money. If they proceed in this direction, then they get the financial reimbursement that they need. The previous rule was only licensed healthcare professionals were allowed to enter orders. Physicians, nurse practitioners, they were the only ones allowed. As of August 23rd, 2012, the final rule was credentialed medical assistants are also allowed to enter medications, laboratory, radiology orders for meaningful use. So that helped free up the physician and the nurse practitioners because instead of having to spend time, I've got to enter this order, this patient needs this medication, this patient needs this laboratory, the medical assistants can now do it. And they do it, once again, under the supervision of the nurse practitioner or the physician. They can't do it by themselves. It's not something independently they can do. They still need that guidance. CMS order rules, only credentialed medical assistants, as well as licensed healthcare professionals, are permitted to enter medications, laboratory, and radiology orders into the EHR and have such entries count towards the meaningful use requirement on Medicaid and Medicare incentive programs, and that's as of January 1st. So you may have a medical assistant who's been there forever. Best thing in the world. Great person, does her job, knows what she's doing. Unfortunately, she's not certified. That's a problem because if they aren't credentialed and you get audited, you're not going to get your money. That's the bottom line. And it's really hard because some of us baby boomers who may have been doing it for a long time, they're not going to want to go back to school. They may not want that education, so we need to find a way to make it easier for them to attain that. But moving on, credentialing must come from an organization other than the organization employing the medical assistants. I'm going to use South Coast as an example because I know it. South Coast can't say, I'm going to start my own medical assistant program because I know we can do this. We have the nursing, we have the educators, we can do this. It doesn't work that way. You have to have a third party, outside group or organization provide the certification. And Tricia's going to talk to you about that in a little bit. An individual who is CMA or AAMA and not current cannot use the credentialing for any purpose and is not credentialed under CMS rules. So maybe they went through the program and they got their certification, but unfortunately they never applied for their CEUs or never kept up their education. And as a result of that now, they're no longer certified. So you may think that they're certified, and maybe they just forgot, they're not following. With nursing, it's every 2 years we have to get certified, we have to get 15 CEUs, so we know that. But maybe, with their home lives or their families, they forgot, I need to have this many credits in this many years in order to keep certified. And if the practice isn't taking care or watching it, and the individual isn't, before you know it, they're not certified, and therefore, with CMS rules, once again, you may lose the money and the financing that you thought you were going to get because they're no longer credentialed. Consequences if the CMS rules are not followed. All core objectives of Medicare and Medicaid EHR incentive programs must be met in order for the eligible profession to receive the incentive payment. In other words, if you're not credentialed, you're not going to get the money. Failure to meet even one core objective would result in non-receipt or forfeiture of the incentive payment. So you may get it initially, you may get paid, but they're going to take the money back. Or entry by someone other than a credentialed medical assistant or licensed healthcare professional could result in loss of 100% of the incentive payment. So, what are their duties? I always look at the medical assistant as being the gatekeeper. They're usually the first person that the client or the patient will encounter. And they have, I think, a unique relationship with those people. They welcome the patient and escort them to the exam room. They measure and record vital signs. They record demographics and basic information about their past and present complaints. Why did you come in today? How long have you been feeling this way? That type of thing. They do medication reconciliations. Are these the medications that you've been taking and prescribed? Are you taking anything over the counter? What are you taking for vitamins? They get all this information. They are the gatherers. They gather information. They arrange the examining room, instruments, and equipment. They change simple wound dressings and obtain wound cultures. If in doing that process they notice, that's a little bit red, it doesn't look good, that's when they need to observe and report it to the physician or the nurse practitioner. They remove sutures and staples from superficial incisions and lacerations. They can administer medications. They can give you the intramuscular shots or the subcutaneous or medication by mouth or put on a topical anesthesia. They can immunize. They can collect blood samples via catheter or venipuncture techniques. The only thing that I recommend is that if you're having them do these tests, these blood tests or any other kind of tests, that you find a way to keep them competent. And this is really important. You need to make sure that if they do one a year, that doesn't deem them being competent in doing that procedure. They need to have some kind of guideline or protocol or policy that states in order for you to stay competent doing this blood work, you need to do so many per year. And we need to make sure that you're doing it appropriately. Maybe have the RN or the nurse practitioner observe them doing it, check them off and say, yep, you know how to do this, you're good to go for another year. And this is with all procedures, yes, ma'am.
Question. So I know the law being passed for the immunization in the community health centers. Right now, the medical assistants in our health centers do not do immunization.
Do you have an RN in the practice?
We do.
Nurse practitioner?
Yes, we do.
They can. They can do it. They can do it. Yep.
They have to be trained.
Yeah, they have to be trained, of course. Well, and actually, when they go through classes, they're usually trained in the classes they take for the certification. But I would also make sure that you have the RN go over the procedure, what they've done, and they have a document that states, on such and such a date, I observed so-and-so giving an intramuscular, this is how they did it, this was the protocol, they did it appropriately, and have her sign it off. And it should be done, like I said, if they're only doing one every year, that's not going to work. You're going to need them to have some incidences where they do a certain amount in a certain time period. That'll keep you safe. Now, they also do filing, bookkeeping, process insurance claims, and book appointments.
Can I just back up to that question? So I don't think that's correct. In a federally qualified health center, you're not allowed to give immunizations from an MA. But Massachusetts did just pass a law that allows the qualified health centers to let an MA give medications. It just hasn't been passed through DPH for
Under
regulation.
supervision.
Right. So
There's
we're not
differentiation
allowed.
between immunization and medication.
I'm talking about immunizations.
Okay, yeah, that's a bifurcation there.
Yes, totally different from medications. But with only in federally qualified health centers. Everywhere else they could.
Okay.
So like Massachusetts just changed that.
Okay, thank you. So they can process insurance claims and book appointments, and they can call in prescriptions and refills to the pharmacy, but only has ordered and approved by the physician, nurse practitioner, or physician assistant. It depends on the practice and the size of the practice as to, some practices will let the medical assistants just do patient care. And then some of them in that practice will just let them do the front office work. Some of them will rotate, where they'll have them do the front office for 3 months, and then the medical assistant for 3 months in the back offices. And some of them, where they're small offices, and there's only one medical assistant, sometimes that person gets to do all of it. So it really depends on the practice itself, and how many people are in the practice, and how many medical assistants, and how many physicians. And that depends on what their role is. What they cannot do, they cannot independently perform telephone triage. This is a big sticky point for me, because the bottom line is they cannot assess. And sometimes it's very difficult when you've got someone on the phone who's telling you, I have mid-sternal crushing pain radiating into my arm, but I ate a hot dog and I think I've got indigestion. It's very hard, because that MA can't assess and say, I think you're having a heart attack. They can't do that. What they need to do is triage it to the nurse or the physician and, say, I think we have a medical emergency here. It has to be kicked up. They cannot do that assessment piece. And I think sometimes it's hard, because I think the medical assistants may get in that position where I've got a stuffy nose, my eyes are itchy, I think I have a cold, oh, is it a cold or is it an allergy? You can't make those assessment skills. You can only state the facts. This is what the patient is telling you. That for the past 2 days, they've had a runny nose, they have a sore throat, and triage that up to the RN or the physician. And I think it's puts them in a very difficult spot, because some of them actually, a lot of them really know that, with their common sense and their years and background of doing this, really know the difference between, I think they've got an allergy versus they have a cold, but they can't act on it. They have to really just stick to the facts. They cannot independently diagnose or treat patients. They cannot give out medication samples. They cannot give any kind of intravenous medications. They can't go near those. They can't advise patients about their condition or treatment regime, and they can't operate laser equipment. And I know there's been a lot of conversation too about them being able to educate the patients. And once again, it's a very difficult area, because they don't necessarily have they're not dietitians. They haven't gone to school for dietitians. So to teach a diabetic about what their diet is, it can be an issue, can be a problem. You can't tell the patient, oh, you're on Coumadin, you really should stay away from green leafy vegetables. That's a little bit difficult. They can't do that. What they can do, though, is if the physician says to them, we have pamphlets in the back room about diabetes, about diet, about hypertension, I want you to arrange for, make an appointment for Mrs. Smith to go see a dietitian, and I want you to give her this information along, and then have them document that that happens. But they can't initiate it on themselves. They have to be directed to do this. Education, they're trained in different places, public colleges, certification or associate degrees, private schools, for-profit, not-for-profit. I think in looking at this, it all depends on what that medical assessment, where they are in life and what they need. I mean, I think college is a wonderful, as you can tell, a wonderful environment. I love it. And for some people, taking that first step into medical assistance in a college atmosphere would also maybe make them want to become a nurse or a blood technician or a radiologist or something like that. So sometimes it's a stepping stone for them. But for other people who want to become a certified medical assistant, sometimes it's a need to, I need to feed my family. I need to have this job, and I need to have it in a fairly quick time frame. And I need to have the classes arranged so that my kids are in school or I have daycare, and I need to arrange my classes around that. So I think it's very individualized as to who decides where they want to go and what classes they want to take and where they want to take them. But the bottom line is they all need to be certified in order to move forward. Because, as I said, I think they're the gatekeepers for medical practices and the profession. So the conclusion is, I think they're a huge asset to any medical practice or healthcare facility. As I said, they're the gatekeepers. They're the ones who see Mrs. Smith maybe every 2 or 3 months and say, gee, you know, Doc, she's got a bruise on her arm. I've never seen that before. Or you know, her heart rate's really fast today, or her blood pressure's really high. They're the ones who see these patients fairly often and are the first key, the gatekeeper to letting them in the door. It's very important that once they become certified, they maintain their certification. So there needs to be some kind of a safety net so that we can provide them with further education so that they'll be able to keep up their CEUs and get the time so that they can get this education. And by educating them more, you're only enhancing the practice because now it opens up new avenues of, oh, you know, Mrs. Smith is on this medication and it's a beta blocker and she's got a low pulse. You're not assessing, you're taking it, you're measuring it. So you can then go to the physician and say, these are her medications and oh, by the way, her pulse was 42. You need to support them in maintaining their certification and recognize that they're a very important part of the healthcare team. And that's it for me. Any questions?
For the programs that issue the certificates, is there any kind of governing body that sort of assesses the quality of the programs themselves?
Trish might know that. I don't. I know that they're mandated. There are a certain amount of credits they have to get in order to reapply for their certification. But I think Trish is going to address that.
I can answer that question when I speak, but if you have any questions on the side, I can answer those after, or I can just do it now and get it over and done with.
Any other questions? Well, thank you very much for listening. I appreciate it.